It's good to be with you all tonight. I'm Baron Lonner. I'm here with Ed DelSole and Randy Betz and all of you to discuss the VertiWedge and InterWedge device that has recently received FDA approval, and some of you are working on getting approvals at your institutions. We've got a lot to cover tonight, and it'll be a case-based discussion. I think we'll talk about some pearls and potential challenges and where this, especially the new approach, the VBO, may go in the future. So we're looking forward to having an open conversation. We just ask you, since the Google Meet format is a little less familiar to some of us, that you just chime in. If you have a point you'd like to make, feel free to just chime in and unmute your mic and give us a talk. So I think, Randy, you're going to get started with an introduction to the device and the approaches.
Yep. Ed, do you have anything to say?
No, just thanks for having us here. I agree with Baron. If there's a comment, question, and anything, just shout it out. Let's have an open dialogue.
Okay. All right. Well, welcome all. So I'll just give you a brief update where we are, especially for those that have not seen what we're doing. Our target population that we put in for the FDA and is targeting vertical foraminal stenosis, be for a patient that has significant leg pain. Back pain can be minimal, but the targeting when the foramen's shut down from cephalad to caudad. And the standard treatment is lateral fusion, interbody fusion to do an indirect decompression. Our new concept with the vertebral body osteotomy is to cut the vertebral body and put a spacer in there, and thereby doing the indirect decompression, but leaving the disc and the facet joints mobile, thus being a motion preservation operation. So this is standard, what it looks like instead of a model. This would be an interbody cage, giving nice height restoration, opening up the foramen, but with pedicle screws and rods in the back. And this is our VertiWedge. This is a cadaver showing that the cadaver had vertical foraminal stenosis and nice restoration of the foramen with the use of this interbody cage. And not interbody, sorry, the VertiWedge cage. Importantly, the pedicles are still free. The cut is below the pedicles such that it doesn't burn a bridge. If you ever needed to go back posteriorly and do pedicle screws and rods, it's still available. It is an FDA cleared device. It's cleared as a partial vertebral body replacement device. They're allowing us to use motion sparing in the marketing of the device. And we also got the indication in degenerative spine disease, in addition to what other companies have to learn trauma. The surgeons that saw this love the concept of the bilateral fixation with the staple concept. So they pushed us to do an interbody device that's similar. So the instrumentation is all the same. And for the interbody, it adds an extra layer of fixation. And importantly, we got a standalone clearance. All the other devices that have a cage and a plate are all in the indications for use from the FDA. It says must use supplemental posterior fixation screws and rods. So we're pretty happy with this clearance. And this, the goal of that is to try and prevent dislodgement of the cage. Even if you're going posterior, occasionally when the patient gets flipped from the side to prone, the cages can dislodge. With our staple mechanism, extremely unlikely that that'll ever happen. So this was a case that Dr. DelSole did. He found this to be very sturdy. Because of the patient's age and osteopenia, decided to still supplement it in the back, but potentially this could have been a standalone case if the patient had the right biology. So at this point, then I'm going to lead into the surgeon training and going to ask Ed and Baron to kind of talk to the surgeons. So I unfortunately can't see who's on the call, but hopefully some of the surgeons that have been to a cadaver lab, Ed and Baron have, but there are hopefully some others that are on that have not been, that have been to the lab. And we'll ask for your feedback about the training. Want to see if we're doing an adequate job training you to get ready to do a VBO. And for those of you who are new that have not seen this, feel free to ask questions or chime in. So, Baron, this slide's just to talk about the ATP or anterior psoas approach and ligating the vessel. Do you have some want to lead into that?
Yeah, I'd be happy to just spend a minute or two. So I've been practicing for a few decades now, and I was trained on anterior approaches, so we always did anterior to the psoas. We'd mobilize it and retract it posteriorly, so we never went through it. So for some of us, it's a very familiar approach, and it's a safe approach. You don't have to worry as much about the exiting nerve roots as they traverse the vertebral body, because you're really retracting it all together with the psoas. And you can see the genitofemoral nerve lying on top of the psoas, and you just retract. I think there's potential for less, the thigh numbness and pain and quadriceps problems. You move along, you expose the segments, you take the segmental vessel in the VBO procedure, and certainly that's how we've done it with procedures where we're doing anterior instrumentation. So I do a lot of thoracolumbar scoliosis, a lot of tether, but also anterior fusions with dual rod instrumentation. And so you take the segmental vessels, and there's a really wide corridor there, and you can use various retractors, and there's plenty of space. So that it's essentially that approach that gets us to the lateral vertebral body, and you peel back the psoas to the level of the pedicle, and then you've got good visualization. So there's a retractor, and I think it's important, and Ed, feel free to chime in. It's important to really bring the psoas back, see the pedicle as it inserts into the vertebral body, and then around the front you have the anterior longitudinal ligament exposed, and then you put this malleable retractor around the front, and it's really got to go to the contralateral transverse process. So you really want to have that go around, and you confirm that on the lateral fluoroscopy view so that you have the protective malleable there, so you can use a bone scalpel and then finish it up with an osteotome that can kind of touch the malleable on the contralateral side. So I think that's very safe and important. And maybe Ed, you can talk about, and others, about what the challenges might be, posterolateral corner, etc.
Yeah, but before we move on, I just wanted to say, this is the specific technique that's being designed for the osteotomy. The lateral interbody fusion device, that can be done in a typical minimally invasive fashion, whether it be anterior to psoas, transpsoas, whatever your typical technique is, it can be adapted to that. The instrumentation works fine for that. With the osteotomy, you do need a larger exposure, number one, for safety, and number two, for implant insertion. And we'll go through some of the mechanics of implant insertion, but just to echo what Baron said, taking the segmental allows you to really get anterior safely. And it seems, when you do it in the lab the first time, if you haven't yet, getting fully anterior around the front of the spine with the malleable seems like, a thing that's hard to do. And it is, there is a feel to it, but once you do it a couple of times, you realize that it is actually a very achievable retractor placement. So I think that's where cadaver work really will pay dividends, trying to understand how do you technically do this. So you can go on.
No, it's great. Good points. Excellent points.
Any other surgeons that have been to a cadaver lab on that care to comment?
Yeah, Randy, this is Roland Kent. I'm on. It looks
Yeah.
like Shervinda's on too. Want to let you know that we're here. Yeah, I mean, this is an unfamiliar approach when you're doing the intervertebral osteotomy, but it's a very familiar approach to the spine itself. And so, I think there's a lot of lessons being taught right here, especially with use of the malleable that don't apply to the interbody, but apply to the intervertebral osteotomy. And I agree 100% that this is something that is very good to learn in the lab. I actually appreciated my time at the training session because we got to do 2 separate levels, and you definitely learn a lot by that second level.
Roland, what tips and tricks? How did you feel about getting across to the other side, and especially to the posterior border of the vertebral body? Dura. Did you green stick it? Do you do an osteoclasis? How did you approach it in the lab?
Yeah, it's more of an osteoclasis type where I get very close to it and then just kind of use whatever I have at my disposal. In this case, I used an osteotome and just tapped that across the far end. But when you got the visualization that you guys demonstrated on one of the prior slides and you have that malleable in place, I mean, I think your visibility is incredibly good to do this. And I don't know what you have posteriorly there in the neural foramen. Do you know what that instrument is?
The Penfield.
That's what I thought. It was Penfield 4. I mean, that's exactly what I used in the lab. And I thought once I could visualize that from the neural foramen all the way to the anterior cortex, I did not feel that the osteotomy itself was technically that difficult, but I liked going right up to the end of it and then just finishing it with an osteotome.
Any concern, Roland or Shervy or anybody, with the Penfield 4 and the foramen? And Bob Gaines used to do this all the time when he was doing his bone-on-bone interbody fusions for scoliosis. Yeah. He would do it as well. But in this population with degenerative disc disease and potentially adherent dura, any tricks or potential concerns that you have with passing the Penfield?
No, and I felt that was fairly easy. If I was doing this not in the lab, so meaning not on a cadaver, I would definitely want to be taking that in and out, just to be looking at the exiting nerve, time and again. And so anytime I'd be doing any work through the osteotomy itself, I would have it in. As soon as I'm not doing that work, I'd have my assistant take that back out.
Sure. Any points?
I mean, I also have done a bunch of anterior work, and it's, with the inner body stuff, we spend all our time on the disc space, but that vessel segmental lies right in the valley, and it is big. It's not small. It's easy to see and to ligate and take. And then once you do that, it really does peel open, and you can see those serosal bands to dissect in there. In the lab, passing this malleable was a feel kind of a thing, but the malleable, Randy taught this technique of dilating it up using small to larger malleables. That was really quite good because it sat into the valley of the body and snuck around really nicely. And then the serial kind of spreading really made it really pretty smooth to get there. And then as far as like passing the Penfield 4, that I think would go really pretty well live. Usually the adhesions ventrally are around the disc, and we're really just under the pedicle really in this approach. And so usually that part of the body dissects pretty well off the ventral dura.
Excellent. Let's see. Billy, Vika, Shalene, anybody, any other points? What about L4 level? The psoas starts to get a little larger there. Any issues with, and you've got the iliac wing there sometimes. Any tips or tricks or pointers for that? I mean, with inner bodies, you've got the same issues. So what sort of helpful tips do you have on that?
This is Michael Bull. I'm here too. The anterior approach, like what's been said, there's a lot that gets said out there about these Mickey Mouse type psoas muscles and things. With what everybody's saying, when you go anterior to psoas and mobilize those psoas muscles, you can get to L4 pretty easily. You just have to make sure your incision's planned with the iliac crest and that you're mobilizing that psoas broadly to pull it back. L4 is very achievable with this. If you can do an L4-5 discectomy, you can certainly do an L4 osteotomy. It's just a matter of bringing your incision anterior a little bit and getting that psoas mobilized. Even when the psoas is very anterior, you can still bring it all the way back.
And Michael, would you use a Penfield 4, especially at that level where you have such a beefy psoas, and especially some of the patients are really, I've seen some giant psoas muscles and they can be really beefy.
Yeah. I mean, a deaver blade that you pull back. Key thing is not trying to do it real focally. If it's very anterior and very beefy, you've got to have a little bit more exposure so you can cover a couple, a level above, a level below with pulling the psoas back. But yeah, any retractor of your choice, whether it's a Penfield or a deaver blade or anything you can get in there to start to mobilize it across a few levels, it'll come right back. You just have to find that plane. And usually there's a good amount. If it's a big person, there's usually a good amount of fat defining that plane, creating a safe separation between you and the great vessels.
I mean, the Wiley works really well for this, and I, having trained on thoracolumbar anterior approach, I mean, this approach is that approach, and it is a powerful approach. It really, I mean, we're doing it through a much smaller incision than that, but you used to could open T10 to L5 with that and move the whole thing. We're obviously not doing that, but the point being, there's not something drastically alien about this approach that we're talking about. This is tried and true in spine surgery.
I think you make a good point, Shirley, about, and Michael made the point, especially in the early cases, I would make a little bit more of a liberal incision. You really want to have good mobilization of the psoas and visualization. That's the key, and not be fighting. You want those first cases to go smoothly, and then you can make those incisions smaller as we go.
Yeah, I mean, both of your points, everything old is new again. These lateral approaches were the gold standard, tried and true for a long time. And they were proven decades ago to be safe, still are safe today. Just need to relearn them.
Yeah, but the only thing is now you get many people that are going to approach this as just trying to use it as an expansion of a lateral, and it's not. It's a true. It's a true anterior lateral approach, not just an MIS discectomy approach.
I agree with you, Bill. I was just saying that today with Dave after my case. It's like you almost have to divorce yourself from lateral interbody fusion and start thinking about the osteotomy as a totally different approach, incision, angle that you're taking. The instrumentation really is like sort of analogous, but still fairly different. You have to be thinking about an osteotomy a lot differently than you're thinking about your typical interbody fusion.
Good points. One of the issues that has come up in some of the labs is, it's relatively straightforward to find the kind of the starting point just below the pedicle on the ipsilateral side. And I think it's really important to aim just below the pedicle on the contralateral side, where it can get a little more tricky at times. So anybody encounter that where they got into the contralateral pedicle or even the ipsilateral pedicle, or did you all?
Baron, we're going to show some slides on that, so maybe hold that for a minute. Baron, before we go off this slide, just want to say this is not meant to keep the Penfield in as a retractor. Like Michael and the others said, use a deaver or some other retractor that you can intermittently pull the psoas back. This was meant just to show that where the starting point of the osteotomy be, where the foramen is, not to use as a retractor. So, Baron, you want to talk about, you were leading into the osteotomy on the
Yeah.
ipsilateral side here.
Yeah, so you really just want to start below the pedicle as shown here, and then coming across, starting with a bone scalpel is nice to have because it tends to bleed less. The bone scalpels aren't long enough generally to get across to the other side. So get it started with a bone scalpel, front to back, kind of start in the middle and work your way back, and then thin out the posterior cortex, and then finish it up with an osteotome. You can get to the other side, the posterolateral corner. I don't know if you have an axial cut.
Yeah,
Can
I
be a
do
little-
coming up later, Baron.
Okay, but that could be a little more challenging, but I think you just work it slowly, and thin out the posterior cortex, and then it'll mobilize. You can put a paddle in there, right, Randy? We've got a little thin
Yep, we'll
paddle
show that.
going.
We'll show that shortly.
Okay.
I think you really have to make sure you're keeping enough bone in the caudal aspect of the osteotomy that you're going to be able to get your fixation there, get the plate to seat on it. So I mean, the upper body here is showing that maybe the pedicle descends a little bit more caudally on the body. So you may have to upcut into the base of the pedicle just to achieve enough like a distal fragment to actually get fixation into it. So it's something to pay attention to on a pre-op CT or intraoperatively when you're looking at it.
Excellent. There's that posterolateral corner. So showing the osteotome coming across, and this may be a little more tricky because your osteotome, you kind of have to angle it toward the foramen here, and it's got to be just right so that you don't get into the foramen and injure the nerve root. So it's gentle taps, slow and steady. Anybody have thoughts on that? Shalene, have you done this? Right, Raj, have you done this? Raj Sethi, Peter, Pashis?
Yeah, can you hear me okay, Baron?
Yeah, in
How
the
are you?
lab. Yeah, in
Hear
the
you
lab, it's
fine,
good.
Raj.
Yeah. Go ahead. Yeah.
So yeah, Baron, I thought the lab that was done was excellent. I was taught by Michael Bohl, who I have a soft corner for, and he did an excellent job at my table. I think that all of the points that you all are making about the approach, I think I 100% agree with, right? I actually do not think that the approach is the problem for this procedure. I think that will be easily taught, and I think that will be easily reproducible, right? Especially among surgeons that are very familiar with the anterior space, and particularly the anterior to psoas space. I shared this with Randy. My biggest concern is subsidence of the implant, right? And I don't know if that's going to be related to where the location of the osteotomy is, like how far caudal to the pedicle it is. It'll likely be related to bone quality. We're going to be dealing now with elderly folks, and I think in the pediatric realm, you don't see the level of osteoporosis that we do in older adults. So I think it's going to be the subsidence issue will probably be a multifactorial problem, and that's really my only concern about this going forward. I think the approach is going to be very reproducible and easily done.
Thanks, Raj. Shalene or anybody, Ed, any thoughts about that subsidence concern?
Yeah, it's probably. I
Yeah,
think
the other, yeah.
Go ahead, Shalene. Go ahead.
Oh, sorry. No, I was just going to say I agree with pretty much everything that's been said. One of the things we discussed in our lab in Florida was what is the subsidence and then the pressure on the disc. That's kind of an open question. That what is this distraction of the body? What does it do to the adjacent disc? And so that's an open question. I think I would want more practice finding the segmental. I'm less familiar with that and tying it off. So maybe a little bit more practice on that for the anatomy. But otherwise, I agree with what outstanding and a very doable approach overall.
Yeah,
it's a good point.
Baron, that I didn't put the slide in, but we've talked. I don't know the lab you were at, but we used that montage. So if you are worried about subsidence and then you can supplement the body with this absorbable bone cement. So if we have time, I have a slide at the very end. We can cover that, but there is a mechanism, I think, as Raj said, if you recognize that or even worry about it, then it's worth probably supplementing it.
And I use that too, Randy. That's a good point. What about bone cement? Is that something that anyone would consider here?
So I have two questions. Sorry, I can't raise my hand. It's Evelina Berger.
Ah,
First
okay.
of all, just on the plate, what is the minimum height? I know I've done the lab, but I just want to reiterate, what's the minimum height of the vertebrae? Because some people have small vertebrae. So, Randy, what is this minimum height to get something appropriate in there?
It's a good question. So the plate, we've talked about that. Ideally, you'd like to, even if the plate overhangs the inferior, the disc a little bit, probably not a problem. We've talked about that if you're really worried about the plate overhanging the disc, that you could actually cut the plate. You
Okay.
might lose some of the fixation from the screws, but still you would have the staple fixation.
Thank you. And then I have a question on montage. I've never used it. I learned about it from you all, but have any of you had any problems with non-union in PSOs if you use, or this osteotomies if you use montage? Are you worried about a non-union?
I've
not
used it
used
for the
it.
screws.
Go ahead,
only.
Barry.
Yeah, I've used it for the screws. I haven't placed it in the osteotomy defect personally. So I use it to augment the screws, and it has done a pretty good job of increasing the insertional torque. And I've never, my experience in the last 10 years has largely been not fusion, but tether, where it's the most challenging environment because you've got movement. And I certainly wouldn't use it in an osteoporotic bone, but osteopenia I have, because I've challenged the norm of VBT in adults, including today. And with that, I've never seen a screw back out or loosen with montage or without it.
Okay, thank you.
Hey, Baron, it's Peter. Can I ask a question?
Please, Peter.
It's nice to see everyone. Sorry, I
Too.
can't put my camera on. Many of us have done the lab, and I think with a few cases under our belt, I think technically, it's achievable, and a powerful tool. I think of those who've applied it clinically, what has the indication pretty much been? Is it a sagittal plane issue? Are you doing a vertical decompression of the nerve roots? How has it been most utilized to date?
So Peter, it's Randy. Nobody's done a vertiwedge case yet, but
Got it.
after we get through these cadaver cases coming up shortly, then we're going to get into some cases where the surgeons are thinking about cases of VBO. So that may lead into your question.
And Randy, I'm not sure if it's appropriate if I can mention the historical work that you did on this that
Sure.
led to this. So, Peter, it's not quite true that intra-body osteotomies have not been performed. Randy wrote up a series and did about 15 or 20 cases 20 plus years ago in scoliosis patients, most of them, I think, neuromuscular, paralytic, and some idiopathic, where he did it multiple level, essentially the vertiwedge approach, and then temporarily instrumented them and removed it. So it was motion sparing, and he did it at multiple levels per patient. So maybe Randy can fill in some of the details. So it's not just a theoretical concept. He's done them.
Yeah. So Peter, I'm happy to share those articles with you too, but hopefully we'll get we're all trying to learn this together, what the indications are. So we'll get to that shortly.
Thank you.
So Baron, maybe so we can get to the cases, we can go through this a little bit. One of the keys is to make sure that osteotomy is completely cut.
Yeah, you do want to make sure you've thinned it out if you're going to do the osteoclasis, because if you put the paddle in and then you twist it, Raj's point about subsidence is a good one. You can really kind of compress into the vertebral body above or below, and then kind of you lose some of your architecture, and it may tend to subside. So you want to preserve that and really get across contralaterally, thin out take the anterior wall. You'll be able to see the anterior wall very clearly, and really thin out the posterior wall, and hopefully finish it up most of the way, and then just a gentle twist of the wrist for the paddle. And then here you go. Ed, if you want to take over from this in terms of the sizing.
Yeah, so comes in multiple sizes, obviously, and then we size off of there's trial implants, and there's also ability to trial off of this sort of like staple propeller preparation tool. So this can go across your osteotomy or your interbody fusion, past the contralateral side, and then you can create the contralateral space for the staple before you actually deploy it, which can be helpful just to get, number one, some tactile feedback on what's going to happen on that particular case when you deploy the staple. And two, is it really just creates sort of a soft tissue envelope for you to put the staple in. You could theoretically deploy the staple into the contralateral apophyseal ring. You can kind of get it into bone. But I've been trying to really get it on that far cortex and then draw it back. And then, yeah, as you can see, just like any typical lateral-based system, the AP image helps to give you the size.
Great.
The shim this is like the critical, I mean, there's every step, I guess, really is a critical step here, but if you're doing the osteotomy, the shim guide is the critical step because for two things, really. One is it'll prevent your implant from spitting out the front of your osteotomy. Then thing two is it allows for stress distribution across the osteotomy so that you don't destroy the bone while you're inserting the implant. So this is the most, I think, in terms of like hands-on, technically need to learn how to do it kind of component of the operation. This would be it. So this merits multiple trials in an operating, I'm sorry, in a cadaver lab before you do this in the.
Does anybody have a comment or question about the shim guide and how it's used? Okay, great.
Yeah, actually, Baron, sorry, Roland Kent again. We did notice in the lab, there's a little bit of a learning curve with it just because it will engage with the bone and maintain the shim in the right spot. We noticed, and I don't know if this was real or contrived, or that I felt it anteriorized the spacer a little bit as we removed it, just because of the oblique insertion angle of the device itself. And so I almost wonder, with a couple more reps with this, if it might not be smarter to just make sure that far staple is very well engaged versus the screws in place on the near side before the shim's completely removed. But yeah, I'd talk to Randy about that, and we've got some ideas, and I want to get back into the lab and test some of those ideas. So.
Excellent, thanks. Yeah, you don't want these devices coming out front, so that's a crucial point.
Well, and by anteriorization, I should specify it was really, maybe a millimeter or two. It was by no means out the front of the vertebral body.
Yeah.
Roland, I'm actually going to show that, so you can chime in
Perfect.
again when I show that. So.
Yeah, perfect.
I guess the other thing that popped into my mind, you on the posterior meeting that we had, you had talked about an X-fix. I sort of look at this and think maybe. I mean, we don't have a cast bar pin system. I mean, could you do some kind of cast bar distractor for this?
Interesting idea, Billy.
Interesting thought. Interesting thought. It's a matter of bone quality, but you could use those holes then as your screw holes for the plate. So
I think that shim really did open it up nicely and really guided in there really pretty well. That I think the cast bar, I mean, none of us have done it live, right? But in the lab, the shim really popped it open.
All right.
And I think the cast bar pin would probably not be as effective as the shim.
Yeah. Ed, do you want to finish up on the staple deployment?
Yeah. It sounds like most of you have done it. So we Once your implant's in place, the staple will deploy. You pass it to the far cortex, rotate it, and again, it's tactile feel, tells you when you can pass it. And then once you have it in the position that you like, typically sort of 90 degrees perpendicular to the implant, then you can withdraw it back and grab that far cortex. Has anybody had thoughts about torque limiting the withdrawal of the staple, or has anybody thought about when do you stop pulling the staple back?
I mean, it seems to me you want to just engage that cortex, and even if it pulls into the vertebra a little, you talked about deploying it in the ring apophysis. So I would do it by visualization more than anything on fluoro, but any other thoughts on that?
Hey, it's Alex. I think that's a great point Dr. Lonner made as far as radiographic confirmation, but you do get a pretty strong haptic feedback, at least in the last course. Feeling it kind of self torque out. There is definitely a stopping point when when the teeth are digging into the cortical edge that it's hard to go much past that. But I think feeling that is really important just to get that haptic feedback.
Alex is one of our excellent neurosurgeons at Mount Sinai.
It's weird
So,
you put those
Ed,
two words together, Dr. Lonner. Excellent neurosurgeon.
Ted, we thought about a torque, but we were afraid if we set a torque and the bone was on the weaker side, surgeon might actually trying to get to the torque to get it to snap, might actually pull it through the bone. So we decided to leave it at tactile feel.
Okay.
All right, so these are some cadaver images from the last session. So this happened to be what we thought was really nice restoration of the foramen. This was pre-op over here on the right side, and just visually you can see that. And down here was the measurement, so you gained a half centimeter. What does the I've read in the literature that getting 20 to 30% of additional volume is adequate. Do you anybody have any thoughts on that? Does that seem to be a reasonable amount of increase? Anybody?
I know that Hansen Yuan many years ago had a number of studies in which he measured the foraminal volume and increases with the various procedures. Obviously not VBO, but it seems to me that's probably often very adequate. Question is for any of the participants is whether you think there'd be value to any kind of decompression, the posterior kind of corner there of the vertebra, to help decompress the foramen with a kerosene, let's say. Does anybody think that would have any utility?
Hey, this is Roland Kent again. I think so. I mean, obviously, I don't think any of us have really any clinical experience with it, but I frequently, when doing anterior column reconstruction for ALIF or lateral, if there's osteophyte off the back, and what typically that translates into is far lateral neuroforaminal stenosis, and usually comes all the way medial to be some lateral recess stenosis, I will typically take that down if a patient has rest-related neuritis. So I think that's helpful. In regards to neuroforaminal volumes, I've heard those same numbers, Randy, in regards to 20% increase. I don't know that we know, and I do think that it changes from level to level. So when we get to the lower, more lordotic portions of the lumbar spine, because of the lordosis, even with vertical height restoration, sometimes we don't get as much percentage volumetric restoration through that neural foramen. So that's where I think, studying this device and studying clinical outcomes would help us answer that question a lot.
Sure.
Yeah, nobody knows. I mean, if you look at all the interspinous process spacer data, they looked at that for Vertiflex, X-Stop, and they only ever opined on just percent increase of size. They never had a critical threshold, and even it's something that's looked at even in cross section, right? Dural cross sectional area has been examined, and the only thing that ever weighs out is the really ends of the analysis. Like people who have very tiny dural cross sectional area in the lumbar spine have symptoms, and everything in the middle is sort of mishmash. So
All right. So, Baron, this is the case, if you want to lead the discussion, where on the far side, so the left side had real nice restoration of the foramen, but on the right side it didn't. And it's suggestive that maybe the cut on the far side went into the pedicle, so you didn't get as much height on that side.
Yeah, so this is the side that didn't quite open up, and it looks like there's even, you can see kind of a divot into the pedicle here. So probably the cut needed to be a little bit just caudal to the pedicle and through into the foramen gently there, and that likely would have helped. Now, often you've got a unilateral radiculopathy, so it might not be a problem, but you know, if you want to get a uniform bilateral decompression, you've got to get right under that pedicle. And
I mean, it may add to stability if you really only had a unilateral radiculopathy.
Yeah. Any other comments about that? So I think, you know, one of the points, Ed, I think you made earlier when we were talking, is that you may have to kind of dive a little lower on the contralateral side. There may be some wedging of the vertebra, and there's not much of a piece left to get a screw into. In that case, how would you handle it? Would you be shy of bicortical? Would you just put a shorter screw in? What would your strategy be in that case? Obviously, we're kind of making this up as we go a little bit, thinking it through, because none of us have done a case. But
Yeah.
I think you had a similar case with inner body, and you went short.
Yeah, I say it all the time. I say, well, you take what you can get, or you take what the spine gives you. And in a case like that, yeah, I mean, there's frequently vertebral body deformity that we have to contend with. And I would just keep the screw short. I'd stay within the confines of the fragment, hope that it's big enough in the area where I can control it. Usually that would be toward me. And that would be that.
So those of us considering doing these procedures, are we going to go on the concave side where you've got you've got a degenerative scoliosis and the concave foramen is tight? Or is that the approach? We go on the concavity, and maybe there's more than one root involved up and down. So do a concave approach, open it up and put the cage in that way? Or would some go on the convexity?
I think I would think of it as really being on the arterial side, you know, most profoundly. You know, that would probably be the biggest influencer of how I would access.
So you'd go left side as much as possible to avoid the IVC.
Yeah.
Yeah. Today I was on the IVC side, and it always makes our general surgeon who's with me anxious and nervous, especially as he has his 65th birthday. He's got a little less and less heart for it. But I think it's a good point, Sherby. Left side approach. But if you're higher up, more cephalad, where the IVC is not as kind of in your field as much, would you consider concave side if it's on the right?
Yeah, I mean, I would think that this is where your pre-op analysis of your imaging to see what structures are really going to be close and risk in your point of being higher, where the vascular anatomy is different, is very valid.
So you're going to study the MRI pre-operative.
I'm going to study the MRI and probably be on the left.
Yeah, fair. That's a good point.
I agree with Sherby. I have the same sort of general sense of it in my practice.
We do a lot of right side lumbar curves for scoliosis, so that's why I go there. They really don't go on the concave side for that, but fair. Any other thoughts on that? Okay.
So Baron, this one of the groups decided not to use the shim for some reason, and kind of just plowed the device that didn't really get any elevation.
I see.
So
right.
After they got spanked, they used the shim. Had a nice correction in the one above.
What do you think it is about the shim, Randy, that is important in this case in terms of the foraminal height.
Well,
So-
yeah, if you, we just learned, like, I guess Shervy said that shim, if the osteotomy is completely cut, then the shim nicely opens up the vertebrae. And then it's less apt to subside, and you get the device out on the cortex anteriorly on the far side. So it's less apt to subside. If you don't use it, it just crushes through the cancellous bone.
There's also a pretty good sized osteophyte there. To Kent's point earlier, he routinely decompresses those osteophytes, and you can see it sitting in the L4 foramen right there. So that might be one where you take a few bites of the Keras and help that out. Great.
So this was the one that Roland had mentioned. So it's not terrible, but it was, he had showed this to me that when they pulled the shim out, the device just sat a little bit anteriorly. So we need to figure out, his idea, maybe deploying the staple before you pull the shim off might be a good one. So have to work that out in the lab.